Okay, so that is our cue to get started. Welcome to the IDRPP Autism Echo session today. If you'll take a minute and put your name and contact information into the chat, that would be great. We are recording today's session. We use it for education and quality improvement. You are also able to go back and review these sessions. They are stored on our website as well as the Canvas page. Again, I just need to give a huge shout out to the Autism Council of Utah and the Autism Awareness License Plate for providing the funding for this project. We really are hoping to increase that awareness and understanding on topics related to autism spectrum disorder. So thank you very much to their funding. Key components of an echo session, if you've never joined one, is really creating that professional networking. So if you feel comfortable enough, please turn on your cameras. It gets us all to know each other over a virtual form. It gets us to know who we can reach out to when we have certain questions and where they work. That's why we put our contact information into the chat. So like Jennifer just came across my chat, and if she shared something about something that happens in Montana, I can reach out to her and ask her further questions. It's just that great way of continuing to get to know us all who are out in the world doing the same things we are doing. We also will always have a speaker presenting a topic. Today we have Kristen Alberg, who is a PT at the University of Utah, who's going to be talking to us about autism and physical activity. We then do a case presentation where all of you guys get to share the amazing things that you're doing and know about young kids. So it's a great way to learn more from each other and just get some information out there. We do want to be interactive, even though we're over virtual. So we have Colin Kingsbury, who will be monitoring the chat for us. So if you have any questions, please put those in the chat. Use that as a way to ask your questions. And then again, if there's anyone who has a case narrative, that's a great way to get information from the amazing colleagues that we have on this call, as well as just learning more information about the families and clients that we work with. We do talk about the families we work with, so just remember to protect their individual privacy. If you're unsure of anything, you can reach out to a hub member. Our hub members all have an asterisk in front of their name, so they're easier to find on the chat. Renaming your profile and raising your hand. We've all been on Zoom for a minute, so we probably all know how to do it, but just in case, this is how you can do that. To get a credit of attendance, we email certificates out after the survey is completed. So throughout today's session, Shayna will be dropping the survey link into there, and if you'll take a minute and complete that. Again, thank you to everybody who does complete the survey. It just is a way that we can take back the work that we're doing in these echoes to our funding agencies, as well as to our federal partners, so that they can see the amazing things that Utah is doing. Canvas is where we store all of our information and PowerPoints, things that are shared with us. So if you would like access to our Canvas page, you can email autismecho@aggies.usu.edu to request that information. Again, just a shout out for case studies. Those are a great way to get information about real life situations They are my favorite parts because I get to learn all the amazing things that you all do within your work and get that feedback and take it back to the families that I work with. I know sometimes it's not always the easiest to share a case. So if you have a case that you want shared and want me to present that, that's just another way to do the case study. We do have social media where we share information about resources that are shared with us, as well as stuff about our other ECHOs that we have here at the Institute. So we have our Facebook, Instagram, and LinkedIn. If you want to take a minute and follow us, that would be great. And I am going to stop sharing and turn the time over to Kirsten. So you're on mute, Kirsten.
Yeah, I just realized I was going to say, I will start my share and I realized I'm muted. Go. Give me just a second here. Okay, so, and you still just see the big screen, right? Or the big slide. Okay, perfect. So my name is Kristen Alberg, and I am a physical therapist. I work clinically still about half-time in early intervention, and I also teach the pediatric content in the Doctor of Physical Therapy program at the University of Utah. I'm on faculty with the Utah Regional Leadership Education and Neurodevelopmental and Related Disabilities, and I run our fairly new University of Utah Pediatric Physical Therapy residency. Which is a fun program, a little rigorous, but a fun program. So anyway, my topic today is the physical activity in autism. And I really enjoy talking about this. I think it's a thing that's not, the importance isn't really recognized enough. And so I'm always happy to be able to share a little bit of information about this and maybe get people thinking a little bit differently about physical activity and the importance. So first of all, I want to I gotta fix my thing so that I get these windows out of my way. It's not giving me the, oh, there it is. Okay. So first of all, I just want to take a moment. You all have mostly probably heard about person first versus identity first language. And a lot of us kind of grew up in our healthcare education learning to use person first language, and a lot of advocates, especially in the autism world, self-advocates, really prefer to use identity first language. And so I will switch back and forth between referring to people with autism and autistic people out of respect for both viewpoints. Not everybody shares the same viewpoint, and so I think it's important to just recognize that there are different viewpoints out there. Also, in the DSM-5, autism is defined as autism spectrum disorder. And again, a lot of self-advocates really see their autism as a difference more so than a disorder. And so out of respect for that, I will mostly refer to it as autism rather than ASD or autism spectrum disorder. And then also, I don't have any conflicts of interest with this. So the things that we're going to talk about, first of all, are the impacts of physical activity levels in autism. We'll talk about facilitators and barriers to physical activity. I will talk about common motor impairments that we see in autism, and then some of the research relating to motor interventions. And what I'm hoping that you all get out of this is, first of all, just to have a better understanding of the short and long-term implications of low physical activity levels in autism, and to be able to recognize physical impairments. I don't expect everybody to be an expert on it or to be a PT after this, but just to be able to recognize when a child or a person with autism does have some physical impairments, and then to develop strategies to address physical activity. And that may be as simple as consulting with a physical therapist or a adaptive recreation program to be able to find some way for somebody to get to be more active. But just to be able to recognize that and then come up with a strategy. So just an introduction here, the World Health Organization recommends 60 minutes of moderate to vigorous physical activity per day for school-age children. And in the US, we don't do very well. I think I saw a more recent figure that maybe had us up a little bit higher than 24%, but we're still about a quarter of our kids are getting the recommended amount of moderate to vigorous physical activity. And in autistic children in the US, we're at about 18% there. So even lower than our typical, and really we've got a lot of room for improvement there. We do know we have a lot of research telling us that physical activity levels for children are predictive of what physical activity levels will be for them as adults. So if they start out fairly sedentary and they're not active as kids, it's going to be even harder to get them to be active as adults. And why is that important? For the young child with autism, being physically active really creates opportunities for them to have some social learning. So if you've got a child who's not able to participate in playground play during recess time, they're losing a lot of those social learning opportunities. You know, their peers are all out there engaging in motor play, and they're learning about social interactions. And if the kid's just standing on the sidelines, they're not going to get those same social learning opportunities. And then also, as the child grows, a lot of our physical activities are really where we have a lot of opportunities for social participation and social interaction. So how many of you go walking with a friend, or go for a hike, or you go skiing with your friends, or climbing with your friends, or whatever the physical activity that you like to do, golfing? That's where a lot of our social participation comes about, is through physical activities. And so if kids are not active, or they just don't have good motor skills and don't like to participate in this kind of thing, they're losing a lot of their opportunities for social participation. And then as a physical therapist, you know, it's ingrained in me to know that low physical activities really contribute to chronic health conditions. So as a person ages, your obesity can contribute to diabetes and cardiovascular health and joint pain. And then there's just so many chronic health conditions that are really affected by physical activity. But also today I'm going to talk about some of the shorter term effects of that as well. But we do know that adults with autism tend to score lower than average on health-related quality of life instruments. And so really being able to increase that physical activity and help them with their health can improve their quality of life. Ultimately, for our kids, social participation is one of our goals. And so we really want to think about that social participation aspect also. And when a parent is faced with, you know, when they come to the realization that their child may or does have autism, there are so many things to think about. And traditionally, PTs may be one of the first providers to spend a lot of time with the family, because typically those motor deficits show up before the social communication deficits do. But once the family finds out about autism, there's just so much, you know, it's a bit overwhelming. There's a lot going on, and suddenly that motor does not seem as important for them. And I totally get that. And we really don't want to make this just one more thing that parents have to think about. So as I talk about things today, I want to challenge you to think about it not as a separate thing, but how can we integrate this into what we're already working on and include physical activity as part of our other interventions that we're doing. So I've got a couple of slides here that go over some of the common co-occurring conditions that we see in autism. And I've only listed ones that are really have known relationships with physical activity. So I haven't listed everything that co-occurs with autism. But our top one is that obesity and overweight. And so people with autism are 1.5 to 2 times more likely than the general population to be obese or overweight. And so all of those associated conditions, that cardiovascular health, diabetes, joint pain, all of those things that go along with that. We have a lot of gastrointestinal issues, with constipation far and away being the most common one. I've seen different numbers on estimates, so saying that it's more than 50% is probably a very conservative number there. So a lot of our kiddos have a lot of issues with constipation. And if we know about basic bowel hygiene, it's really just eating fiber, drinking enough fluids, and getting physical activity. So if you've got a child who has constipation, if you get them active, that's probably not going to take care of everything if they're already backed up. But once you get things moving, keeping them moving really helps to keep the bowels moving. And it's just really an accepted part of healthy bowel movements. And we know that gut discomfort is related to behavior, it's related to sleep, and it's related to food selectivity. So, when our kids are backed up, we see a lot more behavior out of them. They don't sleep as well, and that disrupts behavior as well. And then they kind of get on this cycle where the only thing they want to eat is, like white bread or types of food that are even more constipating, because nothing really feels good in their gut. So that's all they eat, and that just kind of contributes to that constipation. And so keeping things moving is going to does help a little bit with their food selectivity. And then sleep is also a big issue that we see in autism. And so it's estimated that 50 to 80% have poor sleep. And we know that this affects their behavior. None of us are at our best if we haven't slept well. It affects how well we learn, and it really truly affects the whole family stress. So if you've got a child who is not sleeping well, there's always going to be at least one other person in the family, usually an adult. Sometimes it's the whole family who is also not sleeping well. And that just really contributes to stress for the whole family. And so sleep is really super important. We have randomized clinical trials looking at effects of physical activity on sleep. We've got that in general population and various disability populations, and also autism specific, telling us that if you can increase physical activity, you do improve sleep. And I'll talk a little bit more about that in a bit. And then we also know that physical activity during the day is an accepted component of sleep hygiene. So not right before bedtime. A lot of parents want to do that. Okay, physical activity is supposed to help. So right before bedtime, they get them all fired up running around. It's better if it's a little bit earlier in the day. And that's just really an accepted component there. We know we have a high incidence of anxiety and autism, and physical activity is used in the management of anxiety really across populations. And that may reduce the need for medications, but it can definitely help with the anxiety. And then with attention deficit hyperactivity disorder, there's a really high rate of overlap there, co-occurrence, and that is because there's a lot of genetic overlap between the two conditions. And so in the ADHD specific literature, we've seen that aerobic activity has moderate to large effects on attention, hyperactivity, impulsivity, and anxiety. And then depression is also quite common in autism, and we know that physical activity can really help to prevent and also to treat depression in the general population. So a lot of the information in these past couple of slides has come from a paper that was published, I think, in about 2020, maybe, so not too long ago. And this paper was really suggesting that physical activity should be considered to be central to management of autism. And one of the main points of the paper, arguments of the paper, was that they felt, and this was coming from some primary care physicians, they felt that if you can at least partially manage or take the edge off of some of these co-occurring conditions with physical activity, that the need for medications would not be quite as high. So as you all know, we don't have specific medications for autism, but a lot of times our kiddos can be on a lot of medications for the co-occurring conditions. And so their main point was, if we can just keep them active, we're not going to need as many medications for these kids. And so as they're growing, that's not a bad idea to kind of minimize some of those medications. But also I want you to think about from these couple of slides, if we can use physical activity to help in the short term with things like behavior and sleep and anxiety, this may become a higher priority for families. So remember when I talked about that families are so overwhelmed when they get the diagnosis, and all of a sudden motor skills becomes a very, very low priority for them. But if we can use that physical activity to really help manage some of these things that are higher priorities for them, and do it in a way that may decrease the need for medications, this would be a good thing for these families. So again, if we can work it into our other interventions that we're already doing and not make it just one separate or one more thing that parents have to worry about or do. So I'm going to switch gears a little bit and talk about barriers and facilitators to physical activity. And so if you look at the inside of this circle here, so this is the socio-ecologic model, you've got your intrapersonal, which is just really referring to the person themselves. So I'll talk in a little bit about motor deficits that we see, and those create barriers at the intrapersonal level. And that might also include their attitude and just the individual characteristics. And then your interpersonal, as you move out a little bit from the person, you've got their peers and their parents and their teachers. So those people that they're having interactions with. And then in the organization, when we're talking about kids, we're mostly talking about schools. And then we've got our wider community and then our wider society relating to our policies and our laws and our regulations. And so in some of the social determinants of health literature, you'll also see this referred to as downstream, midstream, and upstream. So our downstream are really those personal factors, and the upstream is some of the bigger stuff that might make it less of a problem overall for more people. So there we go. So as I go through these next few slides, everything in the red box can be a barrier or a facilitator, depending on what you have. And so at the intrapersonal level, we've got age, how sedentary they are, their fitness, their motivation, their motor skills, and their sleep patterns. So what we see with age is that these kids start out with lower activity levels than typical because they have motor deficits as young children. But we tend to see that physical activity decreases even more as the rules and the required motor skills become more complex. So as the child ages, things just become a little bit more complicated, and they tend to just do less and less and less as they age. The next bullet point is one of those really obvious things that research has proven for us, and that is that kids that spend more time on screens on weekends have decreased physical activity. So yeah, pretty obvious there. We do know that impaired motor skills are a barrier and they just have decreased enjoyment of those activities. So if they're not good at motor skills, they just don't do it. They don't enjoy it as much and they don't do it as much. And then our last bullet point is kind of inching into the next area, and that's external regulation. Positively and significantly is related to moderate to vigorous physical activity and their motivation in PE classes. And so all that means is that if you've got even just a teacher or a peer or just anybody that's providing a little bit of positive support for a child, they will be more internally motivated to participate in PE. And so that's important too. And then that moves us into the interpersonal, which is our social support from peers, teachers, and parents. We know that social engagement increases moderate to vigorous physical activity, and bullying decreases moderate to vigorous physical activity. So if we've got kids being picked on because they're not good at a sport, they're going to like it even less and want to do it even less. So we really want to think about that as we're trying to encourage kids to be active. We also want to think about their preferences for their activities too. And so as we move into organizational, and this again for kids will be primarily the school, and that's looking at what type of facilities and equipment, their PE content, their teacher knowledge, do they have adaptive physical education, and what are the opportunities? So we know that kids with autism tend to get more moderate to vigorous physical activity on school days than they do on weekends. So that tells us that school presents a really good opportunity for us to increase that even more because they're already more active at school. But still, they average less than 15 minutes of moderate to vigorous physical activity in PE, which our PE classes are typically quite a bit more than 15 minutes. So that tells me they're still spending quite a bit of time standing around in PE. And they average about 16 minutes during recess. So there's still a lot of opportunity to improve that even more. And we do know that at schools that if they have good anti-bullying programs, that does facilitate more physical activity for our kids. And it really is, it's one of our best opportunities because it removes transportation and financial barriers because kids are already there, so you don't have to worry about getting them to something else, and it shouldn't cost them anything to participate in physical activity at school. As we go out into the community, there's facilities and equipment and what types of programs are available. And it's really hard as a parent of a child on the spectrum, it's really hard to find a program that's appropriate for your child. And if you find a program that works for your child, they can be expensive and you have to get them there, and not everybody can do that. And if you put a kid in a program that's not appropriate for them, they can just feel really isolated there, and it makes them like it even less. So we want to find activities that are a little bit less competitive for them. And then our last bullet point here is kind of again bumping into the next area, and that's kind of our societal attitudes about sport for competition versus sport for enjoyment and health. And so we're a very competitive country, and we have a lot of people that feel like you always have to compete and be the best at everything. And these kiddos probably aren't ever going to be the best athletes. And so we need to find something that they enjoy and something that's a little bit less competitive so that they can think about health-related fitness as opposed to being the best athlete. And then as we move into our last area, that's society, policies, laws, and regulations. So this is really our access to care and who pays for everything. And so when IDEA, the Individuals for Disabilities with Education Act, was first passed, the intention was that it would be federally funded at 40%. And it's never exceeded 15%. And we've had in the last couple of Congresses, we've had bills out in front of Congress to try to ramp that up over 10 years. I'm not optimistic of that happening in the next, under the current administration. But that is something that needs to happen at some point, is that we bring that IDEA funding up to where it was intended to be. So it's not just on the school districts, because as you all know, our school districts are largely funded by local taxes. And, some areas have better funding than other areas do. And so, if we're able to create some programs at school that removes financial and transportation barriers for families, that could be something that could be really beneficial for these kids. And then our societal, under that arena, we also are looking at what research strategies we use, what's important for us as a country to be researching. So we're going to move into motor deficits, but first of all, why that's important. So let me get my little laser pointer going here. So up at the top, we have motor competence. So that is really our, and this model just kind of shows how a bunch of things relate to each other. So our motor competence is really our coordination, our agility, our athleticism. So this is, if you're going to be competitive in a sport, this is what you need, is good motor competence. And this is what most of our kids with autism do not have, great motor competence. But that is really directly related to our physical activity. How good we are at activities makes us want to do more activity if we're good at it. And our physical activity is really related to our health-related fitness, which really is our musculoskeletal health, our strength and our endurance, our cardiovascular health, our flexibility, and in some models, the body composition will be included in health-related fitness. Here it's listed as a separate thing, but that's all related to physical activity, our motor competence, our health-related fitness. And over here we have our perceived motor competence, which is related to our actual motor competence, but it may not always be exactly the same thing. And the research tells us that the perceived motor competence actually has a bigger influence on our physical activity and these other things than our actual motor competence does. So if a child feels good about themselves and doing stuff, they're gonna do it, and they'll be active, and they'll have better health-related fitness. And they don't really have to be that great at the sport. So we don't want to totally lie to them and tell them they're fantastic at something if they're not, but we want to build them up, provide support and scaffolding for them, and help them feel good about it. And that's why those anti-bullying programs are so important, is at least not pick on them if they're not great at sports. And then that also tells us if we can get them involved in something where they're not constantly comparing themselves to somebody else in a really competitive activity, we can that boosts them up a little bit as well and helps them enjoy it more. So I'm talking really fast. I hope I'm moving at an okay pace for everybody. So I'm going to go into a little bit of motor deficits. And so we know that our motor competence is an important predictor of physical activity and musculoskeletal fitness levels across early childhood. And so this is definitely a contributor as to why physical activity is not as high in our kids in autism. And a lot of people out there are pushing for motor to be considered a core deficit in autism because it is so prevalent. And our current estimates are around 85% of kids with autism have gross and or fine motor deficits or delays. And we see those deficits before we see the social communication deficits. And that is really simply just because the motor skills typically appear before motor or social communication skills do. And so we're going to see those deficits and those delays before we see the social communication deficits. We do know that our motor skills are predictive of social communication and autistic traits. And so this top bullet point is from a study that was retrospective that was done in kids who had diagnoses of autism by the time they were 2 years old. And they'd had a whole bunch of different measures taken. And then they looked at the kids that had really good outcomes at 4 years old. And the strongest predictor that they could find was their motor skills. So the kids who had pretty good motor skills at 2 were the ones who did really well with their autism at 4. We see when we look at, there's a lot of studies done with high-risk siblings, and there's been a lot of interest in looking at motor skills with the high-risk siblings. And so we see that kids, their motor skills at 13 to 33 months are predictive of the severity of autism. And then in the high-risk SIBS, we see that the delays at 3 to 6 months in motor are predictive of language delays at 18 months. We have motor skills at 10 months are predictive of joint attention at 14 months and language at 36 months. And then this last bullet point I'm going to come back to, but ball skills are a really significant indicator of severity of autism. And I will come back to that in a little bit.
And Kristen, we
Yeah.
do have a quick question. Is there a reference for this study that we could put into the chat?
I've got 4 slides of references at the end. Which study in particular are you looking for? Is that the
so it looks like it was Janelle that asked that question. So but knowing they're at the end of the slideshow, I think that answers what
I think I need to start putting my references in because now it's been so long since I read all of these. The 2-year-old and 4-year-old, the top bullet point, that is Sutera. I remember that one off the top of my head, and the other ones I'd have to look at. So and that doesn't tell us cause and effect. The first time I saw that study presented, I thought that it was presented as it was cause and effect, but it just shows a correlation. So we don't really have research yet that tells us that improving motor at these young ages improves autistic traits, but I'll tell you what we do have. I'll get into all of that. So there's a couple of thoughts out there in the literature about our relationships between motor and other domains. And so the first one is motor cognition. And so that's really that we need to understand our own actions to understand the actions of others. So this is really nonverbal communication. So if I don't really have very good body awareness and I've got my arms crossed and I'm scowling at somebody, but I'm not really aware of what my body does, and then I see somebody do that to me, am I going to know what that means? Because I don't really have that motor cognition. So that's really all that top bullet point is saying is if you don't really understand what your own body's doing, how are you supposed to understand what other people's bodies are doing? What that should be communicating to you. And then also motor learning is really the first learning that we do. So a lot of times we think of this as a very different process, but it really is. Motor learning is learning. And it's the first place that we really use our memory. It's the first place we really use trial and error and learn about cause and effect and means to an end. And so it really kind of sets us up for how we learn. And if we're not good and we keep failing and we can't learn from our body in this very early learning that we do, it does make other types of learning a little bit harder later on. And then motors. Oh, sorry, question?
Yeah, you're getting a lot of questions. People are very, very interested in this. Do you see more autistic children with hypermobility than those without autism? If you can answer.
Yes. It's estimated that more than half, and that's actually on a slide coming up, but more than half of kids with autism have low tone and or hypermobility. So those two kind of go together very frequently, not always, but very frequently. Was there another question?
No, you are good to continue.
Okay, awesome. Okay, so then another kind of foundation to motor learning and learning skills is that we really want kids to have a really rich repertoire of motor patterns and motor skills to draw from, so that they can learn to be really flexible and adaptable in their responses. So when the environment throws you a curveball, really the literal curveball, you're able to adapt to that. And our kids with autism are not flexible in their motor responses at all. So they're very rigid in their motor responses and stereotyped and not flexible and adaptable. And so there's some thoughts that this may be related to our cognitive flexibility as well, because this is kind of our first learning that we do. So if we're learning to be rigid and not flexible, does that affect how we think about things later on? And then I will talk a bit specifically about visual behavior skills, and those are related very much to motor development, and they're also very related to social skills. So I will hit on that a little bit more. So these are just some of the relationships. So some of the common physical impairments that we see. So our general tendencies, first of all, I just want to stress that this is a really heterogeneous group of people. So none of these are exclusive to autism. Nobody probably is going to have every single one of these things. This is just what we see really commonly, but none of them are exclusive to autism also. So like you see that a pull to sit if the child has a head lag. In a high-risk sibling, that child is at a higher risk even to later be diagnosed with autism, but that's related to low tone. So that's something that you see in Down syndrome or really anything with low tone, and not just autism. So none of these things mean that a child has autism, but this is just kind of what we see. So our general tendencies are that they're delayed in their motor milestones. They tend to be clumsy. They have a really hard time with novel tasks, and I'll talk more about that. And then they have low physical activity levels. That low tone and lax ligaments, we see that in more than half of the kids with autism. And then just about universally, they have poor balance and postural control, and I will talk more about that as well. And then when we keep our balance, when I'm going to do something, if I'm going to reach out of my base of support to grab something, I don't reach and then have a balance reaction and catch my balance. My body knows what I need to do. It's called anticipatory balance or anticipatory postural control. My body knows what I need to do to make that reach and not lose my balance. But our kids with autism don't do very well with anticipatory balance or postural control. And so they use reactive balance a lot more, which is really exhausting to just be losing your balance every time you take a step or every time you move out of your base of support, to have to catch your balance. And so even though they tend to be low tone and lax in their ligaments, you see them maintain these very rigid postures, because they don't want to move out of their base of support. They're just trying to hold steady and not fall over and not have to catch their balance. And so this really leads to poor adaptability of their movement. We see abnormal gait really commonly. The most common is having a wide base of support and short step lengths. They move in what PTs call in block, which means that rather than having this nice fluid movement with transverse plane movement, I've got just this, I move my whole body as a block. And so when they walk, you kind of see this, moving as a whole block versus this nice fluid movement. They have poor direction control when they're walking. So you might see them just kind of veer. They might go down a hallway and veer off until they bounce off of one wall and then veer down to the next hallway and bounce off of the next wall. Or if they turn their head, you might see them just shoot off in the opposite direction. So their direction control isn't really very good. They bump into things a lot. They may have difficulty with surface transitions. And then we see quite a few of them that toe walk. And we have a lot of kids without autism who toe walk, but kids with autism tend to be less likely to spontaneously stop that and need longer treatments to get them to stop that. We have decreased midline play and bimanual exploration, and this is seen by 6 months of age in high-risk siblings. And this bimanual or this midline play, this is really foundational to self-soothing, bringing the hands to the mouth. And then feeding. It's also foundational to feeding. And so they just don't spend as much time with their hands together in midline. They hang out in more asymmetric postures. And so they don't do that bimanual play as well either, that really develops that central visual field where they're, working with something with their hands right in front of them and really attending to that really closely. And that's something that we see as early as 6 months. So, for me, if I've got a kid and I know they're high risk, any kid I see, if they're not doing their midline play, play. I'm trying to facilitate that at a young age, but especially if they're high risk, I'm like really on top of that. We got to get that midline play. And then they have difficulty doing any kind of dual task where they're doing two things at once. Anything that's linked together and timed tasks can be difficult for them as well. So they tend to, this linking is really interesting, but they tend to just really separate things out. So there's a study done with looking at kids taking, they had to grab balls and put them into a container, and they had big balls and small balls and big containers and small containers. And the typically developing kid, they were supposed to do it as fast as they could. The typically developing kids would, if they had a big container, it didn't matter the size of the ball, they would just grab it and throw it in, but they would only grab it with a pincer grasp if it was a small container, and they had to be more careful. But the autistic kids all had their preference, whether they grabbed it with their whole hand or a pincer grasp. And then they would get to the next part of the task and then have to maybe change their grasp or separate it out. They wouldn't kind of link those two things together. And then we see a lot of deficits in motor imitation. And we know that we typically will see motor imitation before we get speech imitation. And those motor imitations, there's really a deficit there. And I think I've got a slide that talks about that a little bit more too. And then our visual behavior skills, I will definitely go into that a little bit more too. So visual behavior skills are something, I've read a lot of studies that look at motor deficits and autism, and anybody that looks at any aspect of visual behavior has found a deficit there. And we also have now our first biomarker that can be used as a screener that's been validated. We're still some years away from it being used clinically, but that is based on visual behavior. So I'm going to just go over real quickly balance and postural control in 2 bullet points, kind of typical development of balance and postural control and what we see differently in kids with autism. So we have 3 balance systems that work together, and that will be our vision. Our proprioception is our body awareness through our joints and our muscles. And then our vestibular system, which is the inner ear, and that gives us our sense of movement essentially, but our direction that we're moving, whether we're accelerating or decelerating. So when you're on an airplane and you're taking off and you feel that acceleration, a lot of you're getting pushed back against your seat, but you also feel it in your vestibular system. And then once you're up flying and you're moving along at 500 miles an hour, you don't really feel that motion anymore. But then when you come down and land and decelerate, you really feel that deceleration. So if you fall or bump into anything, or you know how kids stand on a bed and like to just fall down flat and stop, they're really seeking that vestibular input when they do that. And it's also our internal sense of vertical. So if I'm underwater with my eyes closed and I don't have any somatosensory input to tell me which way is up, hopefully I still know which way is up. And that would be my vestibular system that would let me do that. So really super involved in our balance. And all 3 of these systems really work together to provide multisensory information. And our central nervous system then uses that information, and it forms an internal representation of what motor skills should look like. So if you're going to do a novel task, if you're going to go out hiking, say, and you've got to go across a stream and jump from rock to rock, you're going to look at that and you're going to be able to picture in your mind like how far you need to jump, how much muscle force, how you're going to grade it. Are you going to land on that rock, or are you just going to touch it and jump to the next one? So you form this picture that's not just a visual picture, but you're also, you know, you've got your body awareness, how you need to grade that muscle force, and different aspects of that, what that skill is going to look like, and you're able to picture that in your mind before you do it. And if you're not able to put all of that together, that's really makes it really difficult to form that picture and to do that novel task. And our kids with autism, we know that they have trouble processing information from even a single sense, but then you've got to take these 3 different complex senses and process it accurately and then integrate it all together to be able to form that internal picture. And so they do not do that well. And that's really why those novel tasks are so difficult for them. So I see kids with autism go to a playground, and I'll see a kid that doesn't have autism go to a playground they've never been to before, and they just take one look at it and they can just figure everything out and just do it, you know, even though they've never been there before. But a kid with autism will stand on the sidelines and just look at those things for a long time, trying to figure out how to do it and just really have no idea where to even get started. And that's because they can't form this internal picture. And then our typically developing children use vision as their primary balance system until about age 4. And they're especially using their central visual field. And then they shift their gaze a lot to be able to reference things in the environment. So as you're walking and moving around, you've got to really reference things. So you've got to be able to look from one thing to another, but you've also got to be able to really focus on things with that central visual field. And so that's what we see typically. But we know with our children with autism, they have trouble using, they don't use their vision well. And so they rely primarily on their proprioception or their body awareness, and it's just not as effective or efficient in the first place. But if they're one of the more than 50% that have low tone and or lax ligaments, their proprioception isn't even going to be that accurate either. And so it's just not as efficient for them. And so this is why they just tend to be a little bit clumsy, and they don't have that anticipatory postural control. And so it just really affects the way that they move. And one of the things that we've seen too with some functional MRIs is that if you challenge their postural control, you get increased activity in the frontal striata as compared to the cerebellum that you would see in typically developing kids. So what all that means is that they have to think harder about maintaining their posture. They can't just do it. They have to actually really think about it. And I'm going to talk fairly briefly about visual behavior, and this is a framework that I came across in some autism literature. I see a lot of references to things in this framework, but not necessarily the framework itself. But I really like frameworks because it helps me organize thinking and make it a little bit easier to describe and explain. And it's really just a framework about how we use our vision. So it's not the same thing as looking at vision. It's just looking at how they use whatever vision that they have. And so if they have some vision and some ability to fixate, they can demonstrate some visual behavior. And this is a hierarchy of skills. So at the very bottom of this, the foundation is the use of our eye muscle. So being able to track a moving object, being able to move our eyes from one thing to another, and being able to converge and diverge our eyes so that we can judge distance. And then the next thing is visual attention. And when I first was looking at this, it was really counterintuitive to me because I thought if you're going to watch something move, you've got to be attending to it first, right? But actually, if you take something like a small pin or, your thumb or something like that and try to really look at it and attend to it, you'll realize that your eyes are kind of moving over it. And if you try to not move your eyes and attend to it, you'll realize that you kind of zone out from that, instead of having that nice central strong focus, your eyes will just kind of zone out and you won't really be looking at it as well. And so you've got to be able to use those eye muscles before you can really truly attend to something. And we'll see a lot of our kids really don't look like they're attending, or they might look at us and look like they're looking over our shoulder and they're really using their peripheral vision instead of that strong central visual field. And then the highest level of this behavior framework is visual motor. Excuse me. And this is where we're really using vision to direct our movement. This could be as simple as I'm going to reach, I've got a pen on my desk here, I'm going to reach and grab it. My pen's not moving, I'm not moving, I'm just using my vision to direct my hand to pick this object up. But it gets a lot more complicated. And as I start moving and using my vision to navigate through my environment, I've got to stabilize my visual field. So this requires my eye muscles to coordinate with my vestibular input so that I can keep my visual field nice and stable. And if these systems aren't working together properly, it's like when you're FaceTiming with somebody and their phone is all over the place and you see everything's just blurring and jumping around. That's called oscillopsia. So that's what happens when those two systems aren't able to integrate and work together. So the integration of vision and oculomotor with vestibular input is super, super important. And if you can imagine, it's really disorienting to an adult when they have something take out their vestibular system. But if you can imagine for a young child that doesn't even really know how to move yet, and these systems aren't working together properly, every time they're moved, their whole visual field jumps. It makes them a little bit rigid, makes them a little bit uncomfortable with movement and not super excited about doing things. And so this is all really important to be able to get that gaze stabilization. And remember back when I talked about the ball skills predicting severity. And so that's really that that ability to use that vision, to first of all track them and be able to move and direct your vision related to those ball skills. And so we know that kids that have more trouble with their visual behavior are going to tend to be a little bit more severe as far as their autistic characteristics go, and their motor skills as well. So that's one of our big relationships there. So when we look at motor impairments related specifically to visual behavior, we have deficits in visual attention, visually guided by manual task tracking, gaze shifts, or also called saccades, and eye contact. So all of those really require that strong use of the central visual field. And so our kids with autism don't have an actual physiologic central field deficit, but they just don't use their central field very well. So they're not really able to attend to those things. And so that eye contact is really important there. Decreased discrimination of gaze shift can be detected as early as 6 months of age in high-risk siblings. And so this is a skill that we typically see emerging by about 4 months, and they're already showing deficits at 6 months. And this is one of the big ones. Like, we do see deficits in tracking, but the gaze shift and the ability to disengage from one thing and move to something else is the one that really comes up a lot in the autism literature. And then we also have an asynchrony in using visual input to guide our motor output, and that's on functional MRI. And so this really affects that ability to imitate. And so typically when we get, if I were to do things with my hands, everybody's got these mirror neurons that you see somebody do something and you kind of almost imitate it in your mind, and even if you don't actually move your own hand and do it. And there's just a little bit of a glitch there in kids with autism that there's a delay in that message getting through. And so they're not as good at imitation because of that. And then we also know that our visual behavior really affects our motor development and our social communication. And so in terms of motor development, it's really involved in our balance and postural control. And postural control is foundational to any motor skill acquisition. You really can't do a motor skill if you can't kind of keep yourself in the position to do that motor skill. Usually that's going to be upright. But then also this gaze stabilization that we just talked about, the visual field moving around, that has a really big impact on that. Visual behavior has a big impact on that gaze stabilization. That has a big impact on our motor skills. Our ball skills, so all of those are dependent on functional use of the central visual field. Use of vision to navigate the environment also requires those gaze shifts. And then for our social communication, our eye contact is really dependent on the central visual field. And joint attention and social referencing are really all about gaze shifts. So I don't know if anybody's done the training on the Rita-T, but that is, if a kid cannot do a gaze shift, they are absolutely going to fail that. But it's all about social, joint attention. So if you want a kid to follow your point, they've got to be able to look at you, look at your point, and then look to the other whatever it is you're pointing at. Or if you expect them to look up from what they're doing to look up to you to see if you're watching them, they've got to be able to do that gaze shift. And any kind of social referencing is going to involve that gaze shift, or turning their head to their name. If their whole visual field spins when they try to turn their head, they're not going to turn their head when you call their name, no matter how many times you say it or how loud you say it. If that makes them feel really disoriented, they're just not going to do it. And so a lot of these social communication skills that we see and look at are really dependent on this visual behavior. I personally train because I just work with kids under the age of 3. So I start at those foundational levels. But anytime you're doing physical activity, you're really training this visual behavior if you've got the appropriate challenges, and especially if you're able to be a little bit intentional about it. So playing with balls and working on ball skills trains visual behavior. Practicing stairs trains visual behavior. Walking on uneven surfaces, any of the types of things that we might do for physical activity helps to train some of these behaviors. And when kids get better at these behaviors, I see that their joint attention and social communication really improves as well. I'm going to move on. I'm taking a fair amount of time here. Vestibular impairments is something that we've got definitely some growing evidence. This used to be like a big topic, and then people were saying, no, the research wasn't panning out. But now that we know what we're looking for and using better techniques, our most recent evidence really does support the hypothesis of a presence of central vestibular impairments in autism. And what they used to look for, usually we're looking at a low functioning, we've got a reflex. The vestibular ocular reflex is when I turn my head quickly, my eyes should move the opposite direction and at the same speed as my head so that my visual field can stay in focus. And so typically when we're looking at vestibular dysfunction, we're looking at a decreased gain, so the eyes don't move enough. But what we find in autism is actually more often you get an increased gain. So when they move their head, their eyes move too fast and too far in the opposite direction. And either way, it contributes to oscillopsia. And either way, we need to work on their ability to stabilize their visual field, or gaze stabilization, it's called. We do need more research on our vestibular rehabilitation or gaze stabilization exercises in children with central vestibular deficits. We've got a really huge body of literature on gaze stabilization in adults and a pretty solid body of literature in children that is consistent with adults, but that's mostly in kids with peripheral vestibular deficit. So that would be our hearing impaired kids, where it's the actual vestibular system and not the processing of it in the brain. But we do have some growing preliminary evidence. There was a study done not too long ago with ADHD kids, and that showed that the gaze stabilization program worked really well for them to improve vestibular function and cognitive function in those kids. So it's a little bit different. It's gaze stabilization is kind of the highest level of that visual behavior. And that's mostly what has been studied. So I'm going to go into some of the other specific motor interventions, and I'll probably fly through this pretty quickly, but we know that we can improve motor skills at all ages with the appropriate challenges. And there have been a couple of systematic reviews on this, and it was thought that younger would be better, but older kids actually do really well. We think for gaining postural control, that's really best if that's done early and young. But kids with autism learn really well with explicit instruction. So if you can really explain to them what to do, they can learn really well. Whereas when you're working with a really young child, you can't really just explain to them that you got to put your foot here, you got to lean this way or do this. You just have to have them practice and learn more implicitly. And so actually, our older kids do really well with the explicit instruction. We've got quite a bit of literature telling us that we'll reduce the repetitive behaviors or the stereotypies with physical activity. And then we have some evidence telling us that motor interventions can have effects in other domains. And so there have been quite a few studies done just purely motor interventions and then looking at outcomes in other domains. And they've done well, but it seems like when we combine motor with our other domains, those are really the best for our multiple domain improvements, which kind of makes sense, right? And again, that's going to help the parents out if we're not trying to make them, you got to go do this motor intervention and then now you have to go do this communication intervention. You know, if we can combine things together, that's going to be better for the kids and for the families. So looking specifically at health-related outcomes, strength and conditioning has been shown to improve metabolic profiles and decrease autistic traits and improved quality of life. Basketball skills, just two times a week for 45 minutes for 8 weeks, improved sleep and impulse control. And then dance has been shown to improve general health, independence, quality of life, and interpersonal synchrony. Fundamental motor skills is just looking at basically ball skills, mostly throwing, catching, and kicking balls, but also running, jumping, skipping, galloping, and hopping. And in these series of studies, what they've done is they've pulled kids out of PE to teach them fundamental motor skills and then sent them back into PE. And they come in and they're a little bit better at these skills. And guess what? They spend more time being active, but also participating socially during class. So they're more likely, once they're a little bit better at these skills, to actually be active and then have some conversations with their peers and interact with their peers. Social functioning, this top study I really like. This is Game on Autism. And this was, I think it was Ernie Els in Australia that kind of started this. And it's a 6-week golf program. And serious golfers really care about golf etiquette, which is really just a group of social rules around golfing, right? And so they took these kids out and they taught them not only how to golf, but they taught them golf etiquette, you know, because that's really important. And by the end of the 6-week program, this community had also like an after-school golf program available. And so the kids with autism were able to go out and participate with their typically developing peers in an after-school program without needing to have somebody there to be their aid or direct them. You know, they were able to improve enough both with the physical activity part of it, but also the social part of it to be able to go golfing after school with their peers, which I think is just awesome. There's this other program called Spark, that's sports, play, active recreation for kids, and it's similar to the fundamental motor skills in that it's teaching them some of the motor skills that they've got deficits in and then getting them to participate with their kids. We've got some good results with aquatic therapy, therapeutic horseback riding, and then some people, there's probably people in this group that know more about TEACH programs than I do, but there was a group that used the TEACH program and they just did it with physical activity. So they still had their physical structure and their schedules and they're working on task organization, but they were doing it with physical activity so that they were active while they were doing that. Motor interventions and cognition. This top one is one of my favorite studies because it talks about that cognitive flexibility. So they did a 12-week table tennis program and they found that they had improved motor skills. They also had improved executive function and cognitive flexibility and improved impulse control. And so they came back and retested them at 12 weeks after the intervention was over, and they had sustained that cognitive flexibility, but also started to learn to generalize that to other tasks. And so table tennis is one that you've got to have really unique, flexible, adaptive responses to, and it's not just the same thing over and over. And so I like that study. Nigong is a Chinese mind-body program, and they found that those kids had improved memory and cognitive flexibility. And I like this study because a third of their population had an IQ of less than 70, and they were still able to show some improvements in cognition using the Nigong program. And then exergaming has been shown to decrease repetitive behaviors, increase attention, improve reaction time, working memory, and metacognition. And then communication, we've got some results with therapeutic horseback riding showing increased social interaction and new words, and karate is decreasing communication deficits. And then when we look at behavior, there's quite a few that look at behaviors and enough to have a couple of systematic reviews out there. And so kids that are active will have decreased outburst and repetitive behaviors, improved social emotional functioning and attention and cognition. And we've seen the greatest benefits with martial arts and horseback riding. Yoga has also seen some decreased severity of autism and outburst, and then the Chinese mind-body program as well, improved self-control and decreased outburst. And so we know even with our typically developing kids that physical activity during the day really improves their behavior and attention. But one thing that's really unfortunate with this population is that they might wind up being missing recess because they've misbehaved or because they haven't gotten their work done. So they might be kept in during school time and not allowed the opportunity to get some activity, which can really help with their behavior for the rest of the day. So just to summarize the motor interventions, a whole bunch of different things have been used successfully and researched and used successfully. So I would say pick something that you have access to and something that the child likes, and you'll probably be successful with it. And just some of the key points is that we have proven short and long-term benefits for health and quality of life in autistic individuals with physical activity. I could just sum this up and say physical activity is good. We know that our motor deficits present early, but they can be addressed at any time. So if you don't catch them in early intervention, you can still work on motor later on and make some gains. And we can integrate this into and augment objectives in other domains. So it doesn't have to be a separate, completely separate intervention that we do. And we want to think about our facilitators and barriers at multiple levels of the socio-ecologic model when you're developing a strategy. So, and then again, just choose something that the child likes. And then I've got 4 pages of references. So if you want to read through them, and time for questions maybe. So, and I'll stop my screen share so I can see faces. Does anybody have any questions? That was a lot of information.
It was a lot of really great information though, and I really loved your points that you made on already including that into what we already do, because thinking about one more thing, that's overwhelming for therapists as well as parents as well as anything. So including that, and we're already lots of times working on that flexibility and adaptability within whether it's conversations or play or anything. And so I think that including some of those physical activities and motor responses is really great. And then I'll leave it open. If anybody has questions, we'll take a few questions before we move to our case presentation. There was one question that came in that says, why do they tend to like to spin, do you think?
A lot of kids, so a lot of times they seek input. So spinning is a vestibular input. But if they just spin and fall over, they're not processing the input. And so it's like head banging is also a very strong vestibular input, because you get strong acceleration and then strong deceleration. But you don't process the information. Whereas when we do a gaze stabilization program, we're really working on them maintaining visual focus while they're moving. And so they're getting that movement, so I might bounce a kid in my lap and but I'm watching their eyes, and I'm wanting them to make sure that they're able to be mostly successful with maintaining visual focus. So they're getting that bouncing input, but they're also processing it and having some output to help it. So we'll see a lot of kids with autism will do a lot of stuff that gives them the input, even like a spinning wheel is kind of giving them some visual stimulation, but it's not a productive stimulation that is, they're kind of seeking what they think they need, but they're not. They're kind of missing the mark just a little bit.
Great. Then it looks like Jesse has his hand raised.
Yeah, I just have a quick question about a difference of like hypersensitivity compared to hyposensitivity. Have you seen any difference within like motor deficits depending on those type of sensitivity ranges? Does that make sense?
Yeah, it does. I think there's so much variability in, because most of our kids are going to have some areas where they're hyposensitive and other areas where they're hypersensitive. So I've not seen any literature that has really differentiated, which senses have, are hyper and hypo compared to which deficits they have. So sorry, not much of an answer there for you.
No, that was good. Thank you.
Others that have questions or thoughts?
So we do have one more from chat from Kathleen, who says, I have a child who bounces his bottom on the floor while in all fours. What could he be seeking with this behavior?
Bouncing his bottom on the floor while in all fours. He's got some flexibility there to be able to do that. He could be seeking vestibular input. He could be seeking proprioceptive input. Most kids will do some rocking before they're really ready to crawl. So if this child's already crawling, then it may be just a sensory seeking. If he's not yet mobile and crawling, it might just be a don't know how to move yet, and I'm excited and I'm trying to build some stability so that I can move. So it kind of just depends on where this child's at.
Great.
Oh, he's walking, but he still does that anyway. So yeah, so he is seeking some kind of input there. Usually any kind of bouncing, rocking, that kind of stuff, they're seeking some vestibular input. So.
Great. Well, that was just wonderful information. Thank you so much. And I always learn something new every time. I've heard this a few times now, so I love it. I am going to ask Stacy to come unmute, and she is going to talk about our case today.
Thank you so much, Janelle and Kirsten. Thank you for your presentation. That was really really informative. I learned a lot, so thank you. All right, let me get my screen shared. We hope this all works. You know how that goes. Okay, hopefully everybody can see that.
Yep, we're good.
Perfect. So I'm not sure if I need to do a quick introduction, but there's my information. I am with Help Me Grow. I'm the director of the Help Me Grow program for United Way, Utah County, and I will be giving our case presentation today. So here's some background on our case today. This child is 20 months old, and the presenting concerns are the parents report that their toddler is walking on their toes and exhibits an atypical walking pattern. The child is unable to cross the midline of their body during play, such as when reaching for toys or performing other activities. The parents are concerned that these behavior could be signs of autism spectrum disorder. The child is otherwise healthy, has normal development with no significant medical history, and no significant developmental delays have been noted. But the parents are worried because the child is not meeting typical motor milestones, especially the ability to walk with a normal gait and engage in bilateral coordination activities. The child does have low vocabulary and is only saying a few words. Interestingly, the parents do report that the child loves to say numbers and will count almost anything. So the primary area of concern for the parents are that toe walking with no obvious neurological deficits. The child has difficulty crossing midline during activities like reaching for toys that are placed on opposite sides of the body. And the parents are concerned about possible signs of autism, as they have heard that motor delays or atypical motor patterns might be linked to developmental disorders such as ASD. The parents are also concerned because that he does not seem to be as engaged as other kids his age, because he doesn't respond to them when they are talking, and he is very independent. Other things to note are that the child does not respond to their name when called, which is concerning to the parents, as they believe this could indicate social disengagement. The child has low vocabulary and is only able to say a few words, which is below typical development expectations for their age. Despite the limited vocabulary, the child loves to say numbers, which I mentioned earlier. And when asked, and he's often repeating them enthusiastically. The parents note that their child is very independent for the age and that he enjoys exploring on his own, often engaging in activities like self-feeding, playing with toys independently, and navigating spaces without needing much adult intervention. This could be seen as a sign of strong self-regulation, but it also adds complexity to the concerns, as it might suggest both a unique personality trait or potential signs of social withdrawal. So additional information that might be important for this is that the parents have been really frustrated with their doctor because he has not made any referrals. And so the parents have made a self-referral to early intervention Part C. They are mostly concerned with his motor patterns, and they have had others make comments about his excessive toe walking. And so what we would like you to discuss in your breakout rooms are, how would you approach evaluating this child's motor skills and developmental milestones? What tools or assessments could be helpful in determining if this is an isolated motor issue or part of a broader developmental concern? Another question would be, how would you address parents' concerns about autism, and what information would be helpful to provide? And what specific milestones would you encourage parents to work on during therapy visits?
Wonderful. Thank you, Stacy. So we are going to go into breakout group. Well, dang, we needed way more time in our breakout group. So, since I was on breakout group number 1, I will go ahead and take some ideas. A few of the things that we really talked about was making sure that we are talking to the families about going and getting a neurological appointment, referrals to outpatient PT, and utilizing the ASQ screener, and then the MChat. So I know I always say just one idea and I give you more than one. So Colin, don't follow my lead and just give one idea so we can get it in before we all leave.
Just one idea, Utah Parent Center.
Okay, Utah Parent Center. That's a fantastic idea. Okay. And then Justin from your breakout group.
We had a long discussion on joint attention and focusing on building joint attention skills through side-by-side play, through getting in the child's gaze, either with eye contact or getting the toy in their line of sight. And then, yeah, that was a good starting point for us.
Perfect. So if everybody all the breakout groups will send their notes to the Autism Echo at aggies.usu.edu. We will compile those and send those out to Stacy. But then again, they're there for everybody on the call, because this is a scenario that we all probably have happen often. What do we do when they come with these concerns, or how do we encourage certain milestones? So go back and feel free to utilize those. We are next month in February. Let me look at my calendar correctly. So February is our next month. That's what comes after January, right? And it's February 26th. And we will be having sensory integration and autism. So an occupational therapist, Kristen, is that her name, Justin? Remington? She'll be presenting for us. And so thank you all so much for joining. Take that survey, really appreciate it, and enjoy the rest of your day.